That's great. And so Dr. Liise Kayler, who is head of our transplant program over at ECMC, is going to be talking about her clinical research project, hardest to place kidney transplant outcomes in the United States. So Liz, congratulations on a great study and a well-deserved award.
Thanks, Anne. I appreciate your acknowledgement of our work, and I wonder if I'm going to be able to advance my slide. Okay, there we go. So this study encapsulates a pain point that has persisted in my career in kidney transplantation. I'm a surgeon for 20 years now. And so it was something I've been meaning to do for almost half a decade. And so I really appreciate getting to work with Dr. Nye and Dr. Kachis to bring this into reality. I have no relevant disclosures. A kidney transplant improves quality and longevity of life at reduced costs compared with dialysis. It's interesting that advancing, oh my goodness. All right. Yet only 20% of waitlisted individuals are transplanted each year in the United States, largely due to the organ shortage. At the same time, kidneys that are recovered for the purposes of transplantation are discarded at about 20% every year. And this proportion is much higher in the US compared to other countries. The US discard problem is largely related to uncertainty about kidney quality and to regulatory scrutiny. My animations are not working out well, so bear with me. There's no way to precisely measure kidney quality. So when a surgeon accepts a kidney for transplantation, they take into account many different factors, synthesize the information, and that's called clinical judgment. Twice a year, report cards of every transplant center's outcomes are publicly published based on national risk-adjusted models. And these models are statistically valid. However, they may fail to capture important donor factors that influence outcomes that are perhaps captured by clinical judgment. So a surgeon that accepts an organ with characteristics that are inherently risky but are not captured in risk adjustment places programs at risk of being rated as underperforming. A surrogate marker of donor quality may be organ acceptance position. As many as 1/4 of transplanted kidneys are refused at least 75 times before eventually being transplanted. And prior studies have looked at this, and they've actually shown that organ acceptance position is not associated with outcomes. But in my clinical practice, I have been forever sure that the judgment does impact outcomes. And so I looked at these studies and noticed that they chose low refusal thresholds at 9 turndowns and 50 turndowns. So they weren't really looking at the outcomes of the hardest to place kidneys. So we hypothesized that hardest to place kidneys have worse post-transplant outcomes, even with risk adjustment by other factors used in national report card models. We looked at Scientific Registry of Transplant Recipient Data, which is data submitted by all transplant centers in the United States, identified a cohort of kidney transplant recipients between the years of 07 and 18 that were adult and that received deceased donor kidneys. As outcomes, we looked at all-cause graft failure, which is a combined graft failure and patient mortality, or as well as patient survival, delayed graft function, which is dialysis within the first week of transplantation. And we performed 2 sensitivity analysis that I will discuss later. The graft and patient survival was examined with Cox proportional hazard regression and delayed graft function with multiple logistic regression. All of these models were adjusted for donor and recipient factors that are used in national models, plus additional factors that are known to influence outcomes in the literature to make sure we had a very rigorous model. The models were adjusted for clustering by donor, multiple imputation of missing covariates was done, although the frequency of missingness was low, and the proportional hazards assumption was met. All right, 73% of the kidneys were placed locally, and amounting to about 92,000 recipients. Now, local placement of kidneys basically means that the kidneys were easy to place. They didn't have to be placed outside of the local tier. However, 27% of the kidneys were placed not locally. And this group was divided by tertiles by the number of rejected kidney offers before the final patient who received the transplant. So looking at the first tertile, position 1 through 4, this actually also represents a easy to place category, since these were required offers to patients that are hard to match. But as you see the boxes go higher, the second position represents the second acceptance tertile, meaning that at least 5 rejections of the kidney to 164 rejections of the kidney happened before the transplant took place. And in the highest tertile, which is the hardest to place kidneys, these kidneys had at least 165 rejections and up to 27,700 rejections before they were eventually transplanted. So looking at the donor factors in blue, the hardest to place kidneys had a higher concentration of low quality donor factors, such as history of stroke, history of diabetes, hypertension, cancer, long cold ischemia time, acute kidney injury, etc. The second acceptance tertile had disproportionately more donors that were at risk for disease transmission, hepatitis B core positive, hep C positive, increased risk kidneys. These are not necessarily low quality kidneys, that there's just an increased risk of disease transmission. And in terms of recipient risk factors, increased risk recipient factors were higher in some groups than others, but sort of distributed across the 4 groups that we were looking at. And all of these factors will be included in our multivariable models and adjusted for. This is a Kaplan-Meier showing kidney transplant overall graft survival. And looking at the bottommost group in brown, you see that there's a significant lower graft survival in the hardest to place group compared to the other 4 groups. In the box to the left, if you look at the actual 5-year graft survival of the local group, it's 75.6 compared to the hardest to place kidneys, which is 70.7. And that's only a 5% difference in 5-year graft survival between the groups. Now, looking at patient survival, there is also worse patient survival on Kaplan-Meier analysis compared to the other 3 groups. However, the absolute graft survival difference is only 3%. Often when you're working with large numbers, significance is easy to find. In terms of delay graft function, which is again, dialysis within the first week following kidney transplantation, the local and first acceptance tertile kidneys had low delay graft function because these are easier to place and the cold time is lower. However, as the kidneys become harder to place, delay graft function significantly increases. On multivariable analysis, looking in the first column at all-cause graft failure, the 4th group, which is the hardest to place kidneys, had an 11% increased risk of graft failure after adjusting for all the donor and recipient covariates relative to local kidneys. Patient mortality was similar across the groups, and delay graft function was significantly higher with an 83% increased likelihood compared to the local group. We did a sensitivity analysis looking at death-censored graft survival. And this basically adjusts for the fact that some people may have had graft failure due to death rather than due to a low quality kidney. And the results were similar. The magnitude of the risk was similarly high, and it was also a significant finding. Another sensitivity analysis we did was removing recipients if they had received kidneys that were placed out of sequence for operational allocation reasons. So what happens is most of the time when kidneys are declined, they're declined for low quality. But every now and then a kidney will be declined because the recipient needs a pancreas or some kind of operational allocation reason. And so if the kidney was ever declined for an operational allocation reason, we remove that from the cohort. And that did reduce the sample size, of course, but the significance remained and the clinically meaningfulness remained the same. So in conclusion, hardest to place kidneys are significantly associated with delayed graft function and graft failure, even after adjusting for donor quality and recipient risk factors. The graft failure effect size difference is small at 11%, indicating probable value in utilizing hardest to place kidneys, especially since mortality on dialysis is so high. But to really test this, a survival benefit analysis would have to be done. However, despite these pretty good findings of using those kidneys, centers using hardest to place kidneys may be penalized since models used to judge transplant programs may not be appropriately adjusted, and this could jeopardize the program status with regulatory agencies and payers. Organ acceptance position is a surrogate marker of donor quality and is a new data source that should be considered for inclusion in public reports to discourage risk aversion and to utilize all the kidneys that are available and affect transformative expansion of organ utilization. The imprecision inherent in publicly reported models should be addressed. Thank you.
Thank you. It was excellent. We do have time for a couple of questions. I'm going to go first. Have you changed your practice based on seeing the data, based on the results of the study, or were you already taking on some of the harder to place kidneys? Just how do you practice knowing all these facts?
Most of my work centered on, for the last 20 years, has centered on registry analyses looking at, and single center analyses looking at different types of hard to place kidneys. There's all sorts of different phenotypes that I've written about and others have written about. So I usually bring that knowledge to the center that I'm at, and it ends up resulting in higher volumes and more transplants taking place. But at the same time, a lot of times there isn't actually an increased risk, but in aggregate, the practice does result in some increase in risk. And, early in my career, it was interesting. People really weren't caring that much about discard. And so over time, the narrative has changed to the extent that death on dialysis is so high compared to receiving a kidney, even if it's different phenotypes of low quality, that people have come to recognize that it's important to adjust for these factors and allow the patient to be transplanted, of course, with informed consent. But a lot of people would rather accept a kidney with a slight increased risk than remain on dialysis for 8 years before they get some better kidney because they're higher up on the list.
Sure. Looking to see if anybody else, and Steve, go ahead.
Yeah, such an important study, and I've been in the heart transplant field for a few decades, and the whole issue of, do you get penalized for taking a really very limited precious resource such as a less than perfect heart is always something we wrestle with, especially for low volume programs where one or two less than perfect outcomes can jeopardize your whole program. So the question that I have for you is, I mean, I can relate totally with what you're saying. For non-standard donors, you brought up the issue of survival benefit analysis. I mean, it's hard with UNOS data to really assess cost function models over time. At what point does it become not cost effective relative to dialysis or non-surgical management? But you wonder here. You're showing that there's increased complications, probably acute increased cost of care. But the real balance here, I think, is the cost effectiveness of donor acceptability criteria. What's the total cost, and how does that relate to non-surgical management if you only have availability of non-standard donors? Do you have the ability in your data set to make a comparison like that? Because in terms of then being able to make an argument with UNOS or others to change criteria, lessen the penalties of using these precious resources, it might be very effective instead of saying, well, I think, we could probably in this patient move forward with using a non-standard donor.
Yeah, I can't do that with SRTR data. Those data usually come out of institutions, I believe. But in most cases, when people have done cost effectiveness analyses, looking at different types of kidneys, they've found them to be cost effective eventually. So, with a live donor kidney, the cost effectiveness or the break-even point is reached at 1 year. And then after that, it's much more cost effective. But with an expanded criteria donor kidney, which is mostly kidneys from older people, it takes about 2 years to be cost effective relative to dialysis. So with hardest to place kidneys, they're kind of a mixed bag of all the different kidneys, whether it's acute kidney injury, donation after circulatory death, all the kind of different phenotypes of risk that can be taken, but still is acceptable. So I expect that if a cost-effective analysis were to be done, it would be somewhere in between a live donor kidney and, expanded criteria donor kidney or high KDPI kidney.
Andy, do you have a short question? So before we move on.
Can I add before that? So Liz, we can definitely do that analysis as a modeling study because we know how much those different complications will cost. And Stu, it was a great suggestion because it's not only cost effectiveness analysis, it's a clinical decision analysis. If the patient has expected survival of more than 18 months, then we know this suboptimal organ will still be cost effective in these patients if they have expected survival less than a certain number of months. So it could be useful both from the policy and from clinical decision making.
Yeah, but the other thing is in our global burden of disease things, we use other criteria like disability life years and things like that.
Disability adjusted life years, yeah.
Yeah, and that's something that sometimes you can model in on this.
Absolutely.
That helps not only clinical decision making, but also evoking policy change, which is important. Like I say, programs get dinged all the time if they go out on a limb like this.
For sure. So that's a great idea. Happy to work on that.
Yeah, thank you, both of you. I noticed Tim asked a question too, so I'll just answer that quickly. Basically, the great thing that I am happy about is I at least produced one study that showed that these kidneys do have slightly worse outcomes, and yet we're not getting a proper risk adjustment for them. And before this study came out, there were two prior papers, the lower turned down at 9 and 50 papers, which gave the message that organ acceptance position was not associated with outcomes. So now that this study has come along, when I'm in meetings with, people at higher levels, nobody's saying, oh, organ acceptance position doesn't matter anymore. This I think is new messaging, and a lot of people in our community were that's why it became an editorial and a podcast and different things, because it is something that is important for regulatory agencies to understand. And up until this paper came out, they were going around saying organ position doesn't matter. And therefore, actually, the kidneys, it was actually an argument for transplanting more kidneys that were discarded, because the heart, in their minds, the hardest to place kidneys were not associated with outcomes. So but they are associated with outcomes, and we have to receive proper risk adjustment for that if we're going to have transformative change. And I think this, the acknowledgement for it that I received from you and others, I just hope that it grows legs and, reaches the right place, but I don't know really what more to do.
Okay, no, you can see why we picked her to be this project to be the winner, because it is such an important topic. But we do need to move on, so I'm sorry we can't take any more questions now.